Good afternoon. My name is Robert Groves. I'm going to present the topic syphilis, a comprehensive look for nurse practitioner practice. Syphilis is a bacterial infection caused by the spirochete known as Treponema pallidum. The bacteria are spiral-shaped and short, measuring approximately 6 to 15 micrometers long and 0.25 micrometers in diameter. Due to its size, the bacteria are not visible by light microscopy. Diagnosis is made utilizing dark field microscopy in an attempt to capture the bacteria's characteristic movements. Treponema pallidum survives exterior to the human body for only a short duration, making direct contact the primary source of infection transmission. The two common histopathological presentations visualized in dark field microscopy are endoteritis, which is an inflammation of the arterial wall lining, and bloated plasma cells. A hypersensitivity reaction also occurs, often delayed from 10 to 90 days, caused by lymphocyte and macrophage response at the infection site. This immunological response results in chancre development. There are 4 stages of syphilis, each with their own physical assessment characteristics. Primary syphilis is characterized by the development of a chancre at the site of the infection. These skin lesions are usually painless, may have a hollow base, and curled edges. Their incubation period can be 3 to 6 weeks after initial exposure. Secondary syphilis is the manifestation of systemic signs and symptoms which occur 1 to 3 months after the primary transmission. This stage most often occurs when the primary infection goes unrecognized or untreated and presents in the form of malaise, fever, muscle and joint discomfort, swollen and tender lymph nodes, and a skin rash. The skin rash typically occurs on the client's palms, soles, and mucous membranes. The lesions appear with a rust-colored hue, are macular, and usually less than 5 millimeters in diameter. Patients with secondary syphilis may also have patchy hair loss or alopecia of the scalp and face. Facial hair loss usually affects the eyebrows. Last, secondary syphilis manifests in the central nervous system as inflamed meninges, resulting in meningitis and or seizure activity. The bacterial load is detectable in the cerebral spinal fluid. Left untreated, the brain can be affected, and classic signs and symptoms are memory loss, motor function, coordination difficulties, and confusion. Tertiary syphilis is rare because detection and treatment usually occurs before that point. The highlights of this stage in the disease process are lesions of the liver, bones, and testes. Cardiovascular manifestations of tertiary syphilis are ascending aortic aneurysm and aortic valve insufficiency. Latent syphilis is simply the stage in which overt signs and symptoms have resolved, but the patient remains serum positive. On occasion, the classic skin lesions of secondary syphilis can reemerge. The current diagnostic test used for determining syphilis is serological testing. The most common serological test used is the rapid plasma reagent, or RPR. However, there is also a serological test conducted by the Venereal Disease Research Laboratory, or VDRL. Last, more recently developed in response to the immigration issue, is a recombinant antigen test developed for use on the border by the United States Immigration and Customs Enforcement Agency. Fluorescent treponemal antibody absorption, also known as FTA-ABS, is a confirmatory laboratory test conducted when there is a positive RPR or VDRL. The FTA-ABS detects the presence of an active infection. It may also be used when a negative RPR or VDRL results to rule out a false negative test. Dark microscopy is utilized to detect bacteria motility. This laboratory test is best utilized with smears from a moist skin lesion. Treponema pallidum have a unique direction of motion and movement characteristics which easily differentiate it from other bacteria. Neurospinal syphilis can be a challenge to detect. The VDRL test for cerebral spinal fluid has a high specificity but a low sensitivity. Often, the microbiologist is left to decide based on cell count and protein characteristics alone. There is also an FTA-ABS test for cerebrospinal fluid. It is the exact opposite of the VDRL test with high sensitivity and low specificity. Most experts in the microbiology field recommend conducting both tests in order to make the final diagnosis. Penicillin G benzathine is a single intramuscular dose of 2.4 million units and is the standard pharmacological treatment for syphilis unless there is a known sensitivity to penicillin. For patients with latent syphilis, a total of 7.2 million units of penicillin is administered in 3 divided doses over a 3-week period. When there is a known penicillin sensitivity, the oral antibiotic doxycycline in a twice-a-day dose of 100 milligrams is administered for 2 weeks. In cases of latent syphilis, the treatment is expanded to 28 days. Pregnant women should be treated the same as non-pregnant women unless there is a penicillin sensitivity. In pregnant patients with penicillin sensitivity, a referral to a specialist should be made for desensitization. Last, neurosyphilis patients will require an inpatient admission for administration of intravenous penicillin. Sensitivity to an antibiotic can result where none were previously observed. It is important close observation of the patient is done for 30 minutes following the first dose. The most common side effect from this particular pharmacological treatment, which occurs in approximately 75% of the cases, is a Jerisk-Herxheimer reaction. The more elevated the RPR titer, the more likely the reaction is to occur. Rarely does a Jerisk-Herxheimer reaction occur while undergoing treatment for latent syphilis. Jerisk-Herxheimer manifests itself in the form of fever, myalgias, and headache anywhere from 2 to 24 hours following treatment. The reaction is self-limiting, and symptom intensity can be reduced by administering a non-steroidal anti-inflammatory drug. Often, pregnant women and neurosyphilis patients can be beyond the practice comfort of the nurse practitioner. For these patients, it is best to consult with an obstetrician for the treatment of pregnant women, both a hospitalist who can manage the inpatient stay, and an infectious disease expert who can monitor for serum therapeutic levels can be valuable partners in managing neurosyphilis patients. There are no known non-pharmacological treatments for syphilis. Syphilis is spread from person to person in 3 ways. First, serum contact through unprotected sexual intercourse. Second, skin-to-skin contact where there exists a break in the dermis of the uninfected person and a skin lesion of the infected person. Finally, from an infected mother to her fetus, which is also termed congenital syphilis. There are no known genetic dispositions for contracting the disease. However, there are many known demographic and cultural factors which can predict disease incidence. First, younger adults up to age 34 have the highest epidemiological rate, while adults over age 40 have the lowest. Second, males contract syphilis at a 65% higher rate than females. Males living in the southeastern and western regions of the United States have higher incidences of disease occurrence than their peers in other geographical locations. Black and Hispanic males, more so than Caucasian and Asian men, have higher incidence of primary and secondary syphilis. However, men who have sex with other men, regardless of other demographic factors, have the highest incident rates and carry a 90% chance of reinfection. Other risk factors which contribute to higher incidences of disease occurrence include being positive for the human immunodeficiency virus, abuse of prescription drugs or using illicit drugs, poverty, being a sex trade worker, and exchanging sex for drugs. Once infected, patients need to understand they are not immune to reoccurrence. The easiest way to prevent reinfection is through the practice of safe sex. Male patients need to verbalize correct condom use. It is important for healthcare professionals to teach correct condom use if the patient cannot verbalize the technique. Patients who meet one or more of the high-risk factors should be encouraged to be routinely screened for syphilis and other sexually transmitted infections. All pregnant women, regardless of risk factors, should be screened during the first trimester. Pregnant women with syphilis are more likely to have a first trimester miscarriage, deliver a stillborn baby, or have a low birth weight infant. Patients who require an injection series or oral antibiotics should be made aware they need to complete the prescribed course of therapy for best chance at bacterial eradication. To prevent the Jarisch-Herxheimer phenomenon from occurring, the nurse practitioner should routinely prescribe a non-steroidal anti-inflammatory medication for the patient to start with a single injectable antibiotic dose. For patients requiring multiple injections or oral antibiotics, ibuprofen should be prescribed for every 8-hour dosing. Patients should be taught serial laboratory testing will be required after completion of antibiotic therapy. These tests should be conducted at 6, 12, and 24-month intervals. The nurse practitioner should have a candid discussion with men having sex with men, patients positive for the human immunodeficiency virus, sex trade workers, and patients using illicit drugs on their increased chances for reinfection if lifestyle changes are not made or safe sex practices not engaged. The article by Campos Oakhout 2017 summarizes the work done by the United States Preventive Services Task Force on many issues, with syphilis being only one. Using statistical data from randomized clinical trials, the task force encourages more emphasis on safe sex education and frequent screening of individuals who are members of high-risk communities. Ghanem, 2015, writing for the Centers for Disease Control and Prevention, also emphasizes screening of individuals with high or multiple low-risk factors. This was among the first recommendations to retest RPR samples, which initially showed negative, through a second confirmatory test to rule out false negatives. These guidelines contain a comprehensive template which can be used to obtain a thorough sexual history with use of professionalism. Klein, McLeod, and Rogers was among the first to write about the need to extend antibiotic therapy for latent syphilis. Their research showed latent syphilis can become active again in response to the immunity response when antibiotics are initially given. To counteract the activation, multiple doses are required. These researchers conducted correlation studies with various non-steroidal anti-inflammatory drugs to determine which would be the best to use in Jarisch-Herxheimer phenomenon. Ibuprofen had the best statistical significance, p equals 0.003, towards relieving the common symptoms which occur. Warkowski and Boland, 2015, address interventions to reach those populations at highest risk for syphilis. Their guidelines include a social history assessment tool to ensure factors are not overlooked. They also provide potential plans for actions or care the provider could engage once a risk is confirmed. Harding and Gannon, 2012, discussed the importance of using 2 laboratory tests in the diagnosis of neurosyphilis. Having these 2 different tests, meaning both sensitivity and specificity, are tested to confirm diagnosis. Since neurosyphilis manifests in the secondary stage, one does not want to miss it, and using 2 tests provides the best current method of detection. Thank you for listening and viewing my presentation. Have a good day.